السلام عليكم ورحمة الله وبركاته. محاضرة اليوم هي عن الاندومتريال هايبربليجيا. محدثتكم دكتورة منال ناصح، أخصائية النسائية والتوليد في كلية الطب جامعة كربلاء. Objective of the lecture: what a student must to know and what is nice to know but it is unimportant. Must to know to define endometrial hyperplasia and what are the risk factors and how to manage these cases. Nice to know but it's an important things to know the epidemiology of endometrial hyperplasia and the how to understand the pathophysiology and the classification of the WHO of endometrial hyperplasia. How to define cases with endometrial hyperplasia. Endometrial hyperplasia defined as irregular proliferation of the endometrial glands with an increase in glands to stroma ratio when compared with the proliferative endometrium. That means when we want to diagnose the cases with endometrial hyperplasia, we need an endometrial biopsy because the diagnosis is a histopathological one. Epidemiology. Endometrial hyperplasia is the precursor of endometrial cancer, which is the most common gynecological malignancy in the Western world. The incidence of endometrial hyperplasia is estimated to be at least 3 times higher than endometrial cancer. Etiology. Endometrial hyperplasia develops when estrogen unopposed by progesterone stimulate endometrial cell growth by binding to estrogen receptor in the nuclei of the endometrial cells. So, cases which have an elevated level of estrogen with unopposed by progesterone will suffer from these diseases. Other elements such as immunosuppression and infection may also be involved. In this picture, we can see how endometrial hyperplasia develops in a patient with a high level of estrogen unopposed by progesterone, how the endometrium will look like. Risk factors. To know the risk factors, we should put in our mind cases which have an elevated level of estrogen, such as an increased body mass index with excessive peripheral conversion of androgen in adipose tissue to estrogen, and ovulation associated with perimenopause or polycystic ovary syndrome. In these cases, it also will suffer from high level of estrogen unopposed by progesterone. Estrogen secreting ovarian tumors. Example, granulosa cell tumor with up to 40% prevalence of endometrial hyperplasia. Drug-induced endometrial stimulation. Example, the use of systemic estrogen replacement therapy or long-term tamoxifen, and diabetes. These are some of the risk factors which may cause high level estrogen in this patient, and the uterus will be exposed to high level of estrogen unopposed by progesterone. This will cause a proliferation of the endometrium and then endometrial hyperplasia. Sign and symptom. How the patient will present to us. Usually we see these patients in the outpatient clinic and sometimes in the emergency room when they suffer from a very heavy severe bleeding. So the presenting symptom mainly is an abnormal uterine bleeding, which makes this abnormal uterine bleeding the patient will present it with us as heavy menstrual bleeding, intermenstrual bleeding, irregular bleeding, unscheduled bleeding on HRT, and postmenopausal bleeding. Classification. In 2014, the WHO revised its classification. The previous classification, they classified endometrial hyperplasia according to the histopathological result, either to simple or complex, and simple will be divided into typical and atypical, or complex, typical, or atypical complex hyperplasia. Nowadays, the complexity is not have any part of the classification. The classification will depend mainly on the presence or absence of cytological atypia. So we will divide it into two groups based on the presence or absence of cytological atypia, either hyperplasia without atypia or atypical hyperplasia. That's all. Complexity have no role on the classification. So how diagnose these cases? Suppose you are a doctor in the outpatient clinic and you face these women who are suffering from an abnormal vaginal bleeding. In order to approach this patient, we should put in our mind bleeding may be due to any other causes. We should first of all exclude the pregnancy. These patients usually presented in the middle age group, such as about 48 years old. So after we exclude pregnancy, we should exclude also an organic cause, such as fibroid, polyp, or any other causes. And then after that, we should put in our mind bleeding in the middle age group. We need histopathology in order to exclude hyperplasia and its or any other diseases. Maybe they have rarely cancer in the endometrium in this age group. So after the patient presented to you, should you first of all exclude pregnancy and then ask for ultrasound in order to exclude organic cause and to see the endometrial thickness, and then you should do histological examination via an outpatient endometrial sampling. This outpatient endometrial sampling done through a tool. It is called a pipple. This pipple introduced into the uterus, and then you can take a biopsy simply without any anesthesia. But this sample may be inadequate, and if the patient have a continual bleeding and she didn't improve, and the sampling give you the result if the patient have no any abnormality in her uterus by histopathological examination, you need to do a hysteroscopic examination. Diagnostic hysteroscopy not like before. It does not need general anesthesia, and it is simple, and it is also can be done in the outpatient clinic. It should be considered that the biopsy failed or non-diagnostic for a patient with endometrial hyperplasia, or the patient has the endometrial hyperplasia has been diagnosed within a polyp or other discrete focal lesion. And in these cases, we need a hysteroscope in order to see the whole womb and show where is the lesion and take a biopsy from these abnormal sites. Rarely we need a CT scan and MRI. Management. After the result of histopathology come to us, first of all we should counsel the patient. The counseling for the patient in order to listening to this patient, to know the wishing of this patient to complete her family, of if she want to preserve her womb, to understand the patient wishes, and then we can discuss the result of histopathology with this patient. If the patient have endometrial hyperplasia without atypia, initially the counseling, the woman should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years, so it is very low. The majority of this endometrial hyperplasia without atypia will regress spontaneously during follow-up. Reversible risk factors such as obesity and the use of HRT should be identified and addressed if possible. So the patient, we should ask her to reduce her weight, control her diabetes, and if she have any drugs, we should manage these cases in order to reduce the risk of hyperplasia. And then follow-up. The management can be only by observation, and the patient lesion will regress during follow-up. Observation alone with follow-up of endometrial biopsies to ensure disease regression can be considered, especially if there is an identifiable risk factor, and this risk factor we can control it, such as reducing weight, and then or if the patient have drugs such as tamoxifen, we should stop it. And then follow up the patient. The follow up every 6 months, and we take a biopsy and see if the lesion is not present or if it is stay, and then we continue follow up every 6 months by taking a biopsy, at least 2 negative biopsies, so that the patient, you can be sure that she will be okay. However, women should be informed that the treatment with the progesterone has a higher disease regression rate compared with observation alone. So you can prescribe a medication for these patients. So either observation or medication. The medication is, as you know, progesterone, in order to make a thinning for endometrial layer. Medication, we can use it. The medical treatment indicated in a woman who failed to regress following observation alone, or a patient is symptomatic, so you cannot leave the patient bleeding without any treatment. Progesterone will help this patient. How we can give the progesterone for this patient? Progesterone either in a form of a tab or Mirena IUCD. The tablet we can give medroxyprogesterone acetate 10 to 20 mg per day, or norethistron 10 to 15 mg per day if the woman declined to use Mirena IUCD. This treatment should be continuous. In order to regress the endometrial lining, we need to give it in a continuous way. Progesterone in a form of levonorgestrel releasing intrauterine system. In these cases, according to the NICE guideline, we can put the first line of their management as the Mirena IUCD, which is levonorgestrel intrauterine system, and we can regard it as the first option for these cases. If this patient is have a problem, you can insert the Mirena IUCD, such as the patient have a big lower segment fibroid, or sometimes they have stenosed cervix, or she have a problem, or the patient is refused to put Mirena IUCD. Then you can shift to the second line, which is a progesterone tablet, oral tablet. Duration of the treatment and follow-up. Treatment with oral progesterone or levonorgestrel intrauterine system should be for a minimum of 6 months in order to induce histological regression of the endometrial hyperplasia without atypia. Endometrial surveillance should be arranged at minimum of 6 month interval. At least 2 consecutive 6 monthly negative biopsies should be obtained prior to discharge from follow-up. So we continue on progesterone, whether Mirena or oral tablet, and every 6 months we take a biopsy 2 negative biopsy, so the patient is well. Is there a rule for surgical management in a patient with endometrial hyperplasia without atypia? Yes, there is a rule, but it is not the first line treatment for patient with hyperplasia without atypia. This will be for cases such as hysterectomy is indicated in women not wanting to preserve their fertility when progression to atypical hyperplasia occurred during follow-up, no histological regression of hyperplasia in a 12-month treatment, 1 year. There is a relapse of endometrial hyperplasia after treatment, persistence of a bleeding symptom, the woman not compliant to progesterone or follow-up. So, in these cases, the patient is not approved, or it is a progress to hyperplasia, or the patient become good and then it is a relapse, or the bleeding is not stopped, patient refuse medical treatment or marina IUCD, we can prescribe hysterectomy if this patient is not want to any future fertility. Endometrial ablation is not recommended for the treatment of endometrial hyperplasia. You can't do ablation in these cases. Why? Because complete endometrial destruction is not ensured and resulting adhesion preclude future endometrial surveillance. This patient, when you do ablation for this endometrium, you will develop a future adhesion. And if the patient develop bleeding again or you suspect anything in this patient, you can't take another biopsy. This will be difficult. And ablation cannot remove all the lesions. Sometimes a focus of lesion will stay inside the uterus and then it will be progress in the future for malignancy, for example. If the patient have an atypia in endometrial histology, endometrial biopsy histology, this patient you only prescribe for her surgical management by laparoscopic approach to total hysterectomy. And the total hysterectomy by laparoscopy is preferable to abdominal one because it is associated with shorter hospital stay, less post-operative pain, and quicker recovery. Thank you. Thank you for listening. And the next lecture will be about endometrial carcinoma. Thank you very much.